Greetings, everyone. We are now in final session of day 2. It's great to be here with all of you, dear Zoom participants. We sincerely apologize for starting with a 10 minutes delay. We are not by any means going to delay the session. They are going to have their time, and we're going to delay a little bit further the closure of the session, so we have all the interactions and the knowledge that we're going to share here prepared. Also with online with us, we have already Cathie Sudlow joining us from Edinburgh, right? And Davide Chiarugi, which unfortunately could not be here with us and present as planned, but joining us from Switzerland. Good morning to you, and apologize for the waiting. Also online, our online host, Dr. Padma Roy, that is going to take some questions here. And without further ado, let me introduce Alex Newberry, the person in charge for research in the Welsh government. It's really a pleasure to have Alex taking his busy schedule to be here with us, hosting this wonderful session on trusted research environment. The floor is all yours, Alex.
Thank you, Paul. Thanks, everybody. So this session is on trusted research environments. We're going to have a bit of a panel discussion, but we're going to kick off with Professor Cathie Sudlow, who's online. It's my absolute pleasure to introduce Cathie. So Cathie is the director of the Usher Institute at Edinburgh University. She also was the author of the influential, quite easily named Sudlow Review that was last year, that was looking at data research, data infrastructure here in the UK. So I'm going to hand over to Cathie to start her presentation, and then we'll have a panel discussion afterwards. Thank you.
Thanks so much, Alex, and very sorry not to be with you. So I'm going to pull up a few slides just to help me, and I'll whiz through them as quickly as I can, just to do a little bit of scene setting. So can I just check, Alex, are those showing all right on the screen for everybody? Brilliant. Yes. Okay. Let's go then. So my opening statement really is about trusted research environments. So I'm not a technical person. I'm a medic and an epidemiologist, and I've turned into a population health data geek. But I don't run a TRE, although I have been involved in using them and in co-designing them and co-developing them. But in my view, to be useful, then the TREs are kind of pretty dependent on the sources of data that they hold. So they need to be populated with the sources of data that are needed for the research projects that they're supporting. They, of course, need to have the technical capabilities to securely hold, link, and enable remote access to the data for those research projects in a way that preserves the privacy of the data subjects. And there are many of you in the room who are technically far more au fait with all of those mechanisms than I am. They need, in this day and age, to support an increasingly broad range of analytic tools. And one of the barriers that analysts who have encountered is the range of tools that are available to them within some of the trusted research environments or secure data environments they work within. And then increasingly, they also need to be able to work interoperably with other TREs that hold similar or overlapping data, covering different geographies, different people, or possibly different data types. So that's really the kind of technical part of my little intro over, and I thought I would just give you a very rapid introduction to some of the work that I did over 23 and 24 leading up to the review that was published at the end of last year, which was essentially a review of the UK health data landscape, which was addressing a couple of things, was for UK government. So to map the linkable health data sets across all 4 nations of the UK, and then to outline some of the barriers to sharing data for public benefit whilst keeping it secure, and identify some of the solutions and make some recommendations as to how those might be overcome. The remit for that second part had a primary focus on England, but actually, as it turned out, and this will be unsurprising to many of you, the barriers were broadly similar across all 4 nations of the UK, and so in large part with the solutions, although of course there are some differences in the detail. And indeed the way things have gone subsequently is towards a set of UK-wide solutions, which I think is absolutely brilliant. So I wrote over 60,000 words in the review, and even the executive summary is kind of quite long, but the Office for Life Sciences managed really well to summarise the review on one slide. So it was basically to point out that we have many sources of health and care, and indeed health relevant data across the UK, with some fantastic initiatives. A few are shown on this slide. There are many others besides. We can't make the most of them because of poor interconnectivity between them, and linkage is absolutely critical, of course, because of the complex and inefficient systems for managing and accessing health data. And of course, there are some notable exceptions where that have really pushed the boundaries and done very well. Some of them delivered by colleagues in Wales. But all of this means that there's huge untapped potential. So our data can support our own care, the care of our friends and families, can inform an intelligent healthcare system that predicts and responds to demands. Data can drive the planning and delivery of equitable care, both regionally and nationally, and of course can support a thriving research and innovation landscape, but only if we have an ambitious and joined up data strategy. And you see on the right hand side of the slide some of the recommendations that I made as a result of the review that was conducted. So some of the key points I made in my review were that we use health data all the time to improve people's health and lives, that generally the public, patients and the public, support the use of their health data, not only to benefit themselves, but to benefit other people as well. A lot of what we ask them about, they sort of expect to be happening, but they do want to know what's happening, and they want there to be transparency around it. They want to know who's using their data for what and who is benefiting as a result. And all of those seem perfectly fair and reasonable things to be asking of the system. A key point from the review that many in this room, virtual and real, will be all too well aware of, but which politicians and policymakers are not always, is that the really transformational insights come when different sources of data and different types of data are linked together. So individual data sets are all well and good, and they can be extremely helpful, but it's the linkages that really adds the value. But of course, there are many obstacles and delays to be overcome, and often researchers, innovators, people in the NHS are waiting for weeks, months, or even years, or even give up in terms of being able to access the data that they want to use to be able to address questions that are in the public interest to know the answers to, because of our complex and inefficient systems. And as a result of that, many people across the UK are being let down. And so one of the points I made was that the UK's health data really needs to be seen as part of our critical national infrastructure. When I said that, I didn't actually know what that phrase meant, or I didn't know it had an official definition. But when I discovered what the official definition was, I still felt that it was a valid thing to be saying. So in terms of the health relevant data, that increasingly should and could be held within trusted research environments or secure data environments to enable its access and use for addressing a panoply of questions by a range of different types of researchers from across multiple disciplines. We have these nationally collated data sets that come from day-to-day activity in the National Health Service and are brought together at the level of each country and increasingly held and linked in secure data environments or trusted research environments, which now exist in each country of the UK. And Wales has done an amazing job with its SaIL Databank, not only in bringing that benefit to Wales that was in place prior to the pandemic, but in helping to build capability in other parts of the world as well, including Northern Ireland. And England was playing catch up during the pandemic, but is now in a much better place than it was. Arguably, it's got sort of more than one or several different offers potentially available to choose from, and some redundancy in the system, not always a bad thing. And then we have local and regional data. In Wales, I'm delighted that the route, the direction of travel is for Wales to operate as one, and for these more granular and detailed data assets like images, free text and laboratory data to be assembled on a national scale. And I'm quite convinced that that's the right thing to do, and I would encourage that to continue to happen. But England, being larger, has to some extent divvied itself up into regions for some of these granular data assets before they're surfaced nationally. There are, of course, many other data relevant to our health held in other administrative systems: census, social care data, income data, justice data, education data are a few examples of those. And then we have a whole bunch of other data that outside of these administrative systems, from personal monitoring, environmental data, and then importantly, data generated through the research community, usually with the direct consent of the participants in cohorts, be they large population-based ones or smaller clinical ones, or clinical trials that can operate at regional or entire national scale, or indeed internationally. So there are many examples of bringing together these different types of data sets successfully. I'm going to whiz through a few just to show you the types of things that can be done, and that started to become more and more possible during the pandemic, with the pandemic as a driver, but rightly should continue to be possible following the pandemic. And some of them, of course, were happening prior to the pandemic as well. But here's one which was linking data from across Scotland, England, and Wales, and then working across secure data environments to bring a national picture together of patterns of medicine prescribing and dispensing during the pandemic. And I won't go into the details. You can sort of see those patterns before your very eyes, and you can read in the pink text there of some of the consequences of this reduction in uptake of prescribed cardiovascular preventive drugs. Very similar exercises have been done for sodium valproate, looking at which is an anti-seizure medication. But in these types of exercises could and indeed should be used as a matter of routine for monitoring the uptake, safety, and adherence to guidelines for a multitude of medicines used across the UK. And then similarly, it's been possible to use similar approaches, in this case across all 4 nations of the UK, to look at vaccine uptake and indeed under-vaccination across all 4 nations of the UK and the consequences of that. And then more granular and detailed data has started to become possible to pull these types of data together as well at the scale of a country, for example, in Scotland of 5.5 million, where all the radiology images gathered across NHS Scotland have been made available for linkage to other sources of health data. And those go back in time, so that it gives the opportunity for longitudinal studies, for example, to look at the role of brain imaging in predicting dementia risk using advanced analytic techniques. And then something that I think is done particularly well in Wales, which is a demonstration to the rest of the UK, is the notion of linking data from across sectors to understand the wider determinants of health. Here's but one example, which has been facilitated through the SAIL Databank, which looks at the impact of school absence and exclusion on subsequent health outcomes in young people. There are many other examples. Many of those that we have in the UK come from Wales because of the success of the SAIL Databank in garnering trust from the health system, but from also other administrative sources of data, and the capability to link those together safely and enable researchers to access them, work with them, and generate these types of insights much more rapidly than in any other part of the UK. And then just a couple of examples of linking data from research studies, or the way in which research studies can be enhanced through linkages to routinely collected data from the health system and beyond. Here are 2 trials you will no doubt have come across: the recovery trial, which used centralised services from across all 4 nations of the UK to follow the health of its very large number of participants, to help ascertain outcomes at a scale that simply would not have been possible without these types of linkages. And then the NHS Gallery trial, which has used similar mechanisms to follow participants' health, but also to find the participants and enable them to be invited to take part in this study. And then we've got large population-based cohorts and indeed smaller clinical cohorts. I could have given many examples. UK Biobank is one of my favourite ones. You can see on this slide some of the examples that have relied on the data from participants taking part in UK Biobank to be linked to their routinely collected health and other records to enable studies like this to take part. The longitudinal linkage collaboration is doing exactly the same sort of exercise on behalf of 28 or 30 or so, somewhat smaller but collectively very large cohorts with millions of participants from across the UK, with the trusted research environment capability being provided by UKCERP, which of course you will know is a development from the SaIL Databank in Wales. So there are lots of examples of these types of successes. Unfortunately, there are many examples where it hasn't worked so well. So these examples tend to be exceptions, but we do have a lot of capability, and a lot of that capability has been demonstrated from Wales. So the recommendations from my review were around critical national infrastructure, investment in a national health data service, which could help to streamline and standardize a lot of the activity that is currently very fragmented and complex. But you'll note that my recommendation 5 is around a UK-wide system for standards and accreditation of secure data environments. And that might be something that we want to come on to discussing, because interoperability of standards as well as of data is incredibly important if this is going to work well for us across the 4 nations of the UK. The review, somewhat surprisingly to me, because I thought it would sit on a shelf and gather dust, has actually been received pretty well across the relevant government departments. It landed at a particular moment in time when the Wellcome Trust was taking a great interest in this area and starting to turn its attention towards the health data research capabilities in the UK. So as many of you know, this concept of the Health Data Research Service has been born through a partnership with significant funding from the Wellcome and UK government. And the Health Data Research Service is currently recruiting for its chair and CEO. Those will hopefully be in place but towards the end of this year, beginning of next, to help launch a government-owned company which will have a UK-wide remit with some core must-have whole population national data sets as the kind of fundamental pillars of its activities, and underpinned by this by a number of principles: the principle of public data for public benefit, secure data environments being a fundamental component to ensure privacy and security of individuals' data. And we've seen all major health research data-driven initiatives move towards providing access to research using secure data environments. UK Biobank, Our Future Health, newer Kids on the Block, the longitudinal linkage collaboration, as well as the large population-based trusted research environments. So we need those to be fully interoperable for this environment and ecosystem to be able to work optimally. So finally, just a few thoughts about Wales, because we're talking about Wales today. I think, and Alex and some of you have heard me mention this before, but one of the things I've been keen to say across all nations of the UK is that it's really important that we don't have unnecessary duplication of effort. Some redundancy within systems is helpful. Having single points of failure is not a great idea, but we can't afford to have multiple duplication of infrastructure. It's simply not affordable or sustainable in this day and age. In Wales, I think you've got the fantastic assets of the SaIL Databank and UKCERP to capitalise on, with your capabilities around the integration of GP data from primary care and cross-sectoral linkages as being essential ingredients that should be preserved and enhanced. And I think the One Wales approach to health, social care and cross-sectoral data and digital infrastructure is a very splendid one, which it makes every sense in the world to preserve. I'll stop there, and apologies if I've spoken a little over time. I hope that was helpful.
Great, thanks, Cathie. And I think you're going to stay on for our panel, Cathie, so there'll be an opportunity to ask Cathie questions as we open that. So I think we're going to have an opportunity just to introduce the other panel members now. So I've got Ashley in the room with me, and I think Davide is on the Zoom as well.
I am.
Are we able to put him up on screen? Oh, perfect. Hi, David. So I was going to just give a chance for you, oh, and Petra as well. Hi, Petra. So I was just going to give a chance for the other members of the panel to introduce themselves. I just thought I would pose each of you a question, just so if you can introduce yourselves and then just give an answer to the question, that would be a great start. So I'll start online. So in your view, what's the most important foundation for a trusted research environment to unlock sensitive data for research? So if I start with David.
Yes, good. So good afternoon, everyone. I'm Davide Chiarugi. I'm the director of the Personalised Health Informatics group in Switzerland and the technical director of the Swiss Personalised Health Network Initiative in Switzerland. So to reply to your questions, based on our experience, actually, the main foundations, the main pillars of a trusted research environments are two. So one is the legal framework, so to say, so to be compliant with the set of rules that actually encompasses all the possible stakeholders. Right? It's not like, so in Switzerland, this problem is particularly intense because of the federal organization. So we need, so our current TRE, which is called BSpace, is actually compliant with all the, let's say, different nuances of rules of all the federated hospitals. And this is one pillar, in my opinion. The other pillar is usability. So these compliancy, they need to be compliant with all the different rules of the stakeholders, brings necessarily complexity into the user's experience. And then we need actually to take care so that this complexity is kept to a minimum, right?
Thanks, David. To Petra now.
Yes, hello everyone. Hello from Berlin, Germany. My name is Petra Ritter. I am a professor for brain simulation at the Charité University Hospital in Berlin. I'm also director for international affairs at the Charité, and I am leading a couple of large-scale European projects. So the largest one is the European Testing and Experimentation Facility for Health, AI and Robotics. And several of these European projects also involve the development and operation of trusted research environments. So what do I see as very important? Really, it is sovereignty and autonomy. Yeah, and this is how our trusted research environments are being developed. They are completely open source, which provides many advantages. So we are not running our health data processing on Microsoft or Amazon services, but use open source platforms that are self-developed and maintained and operated on premises. And there are several advantages of such open source approaches to software that is used for example, trusted research environments. First of all, sovereignty. There's a better control of data. Open source allows organizations and individuals to host and manage their data on their own infrastructure, and reduces reliance on proprietary cloud services, for example. Also, transparency, access to source code means that users can verify where and how their data is stored and processed and ensure compliance with the regulations that do apply. There are other advantages that I don't detail. I just wanted to mention them: security and privacy. We can go more in depth. But I think it's really important to mind sovereignty and autonomy and avoid dependence from large providers, especially also outside of our European region. So I'm from Germany, I'm European Union, you are UK. We have very similar legislations in terms of GDPR, for example. And I think it's important to collaborate. And the legislations reflect the values that we have together. And therefore, it's important to make sure that we have full control and that all the regulations that reflect our values can be maintained and put in force and in application.
Thanks, Petra. And finally, panel member Ashley in the room here.
Morning, everyone. So I'm Akbari. I'm a professor of population data science research based at Swansea University. I'm also head of the user and data support services and research innovation at the Sale Databank. So your question going back to it, so I build on a lot of the points already raised by the panel. I guess the additional ones I would add in are, so trust and transparency being key, both across a wide range of stakeholders, from the data owners you're trying to unlock the sensitive data from, but members of the public and other key stakeholders. And I guess the main other one that hasn't been mentioned yet is what I'd call incremental value and impact. So building on good examples to show why you want people to share the data with you. If you can't tell them why the data is potentially valuable and impactful to them, it makes it a lot harder to sell it as a good example as to why they should sell their data. And we heard examples from Em this morning and others. There's a lot of good examples out there across Wales and the UK. I think showing those examples then tries to sell that opportunity as to why they can have value back as a data owner to share their data owner with you.
Thanks, Ashley. So I've got a couple of questions up my sleeve if we need to, but I wanted the opportunity to open out to the audience. I can pick up questions here in the room. I'm assuming somebody is covering anything that is going to be online. Excellent.
I'm online.
Anybody with questions?
There are no questions online so far. If you would allow, I may have a question or two.
No problem. Any questions in the room before we go? No? Well, I've got one that I would pose to the panel. So given that we've got kind of expertise from across Europe here, and Petra, you mentioned about kind of some of the regulatory regime is common across the UK and Europe, but not all of it is that going to be the case. What do you think is sort of the contrast between the way that things are developing in Europe and the way they're developing in the UK, and what that mean about the opportunities? Maybe start with you, Petra.
Yeah, thank you very much. So actually, in many cases, UK is already providing very good blueprints for the rest of Europe, for the European Union, to my opinion. So we always look across the border to see how the UK is doing this. One example that I find very impressive and that I very often mention actually in these debates with, for example, members of the European Commission or other member states, is that we also need proficiency and literacy of the people to work with the regulation and to know how to work with the regulation. And this requires education and training. And I learned that in the UK, there's actually such a centralized training for health data proficiency and the registry where the passing of such trainings is be certified and stored, and is a precondition for then accessing sensitive health data. And I think this is fantastic. I really would like to see this also in Europe, to give you just one example. And of course, I'm very keen to foster cross-border collaboration, interoperability, not only technical and semantic, but also legal interoperability, which requires the careful evaluation. And even if there are differences, there can be streamlined processes to take these differences into account, yeah, and that they then need to be provided to the society as blueprint solutions. And once this is available, it is very easy, even if there is some degree of heterogeneity, to follow these examples. Yeah.
Thanks, Petra. Anybody else on the panel want to offer a view?
Yeah, I have one question for Cathie. So, Cathie, your presentation is wonderful, but how can trusted research environments balance the need for the secure data access with interoperability across the UK? And what are the governance and partnerships are needed to link national NHS datasets with more granular, regional, and local health data?
Yeah, I mean, those are two quite chunky questions. So in terms of interoperability across the UK, even we even have some challenges within the UK on slightly different legislative frameworks across the four nations. So the challenges of like linking data internationally, say between the UK and Europe, and finding ways of safely sharing data for programs of work that need scale up, that also need to be addressed within countries. And I guess within some countries there are different laws across different parts of the federal systems and so on, so that every country has its own particular challenges. But so I think part of it is through the standardization of the sort of requirements of, well, what makes a trusted research environment a trusted research environment? What gives, and how can it be accredited? So I'm always reminded when talking about this of when I'm a neurologist and I used to work on looking after patients with stroke. When it became clear that stroke units improved the care of stroke patients and saved lives and improved outcomes, hospitals started opening up stroke units like there was no tomorrow. And sometimes they would just like create a stroke unit by slapping stroke unit label on the door of the ward that the stroke patients were looked after in, but nothing had actually changed. So that's clearly something that we really need to avoid. So I think it's quite, I think we are developing now, certainly in the UK, a set of standardized criteria that make a secure data environment or a trusted research environment that thing. And Ashley's probably a little more up to date than I am with exactly where those criteria have got to. I know that there are some trusted research environments that have sufficient agility and already have a lot of the accreditations that already exist in place, that they will very rapidly be able to acquire any new accreditations that are necessary. And there are others that are more early in their journey, that where it might be a bit more of a stretch. And I suspect that will be true of any country anywhere. But I think a shared set of standards and meanings as to what are the essential ingredients of a trusted research environment, both within countries, across the UK, for example, but also between countries, is going to be increasingly important. When it comes to different data types, I mean, in the UK, the main data types that are held securely and linked together and for which the access has been enabled at whole country level have been largely highly structured data, and they haven't included, by and large, more complex data types like images or free text. I think it's likely that those data types will need to be processed before they can then be provided within the very large scale environments, national environments, so that's likely to be more efficient. But I'd really welcome the comments of others. So for example, imaging data, deriving values from the imaging data that can then be held, that can then be more readily moved around and held within secure data environments, or more readily shared through a range of different federation systems, will be more straightforward than doing it, than moving those entire granular data sets lock, stock and barrel around. But I'd be very interested in other people's comments on that. We know in Scotland it's been possible to do this with images at a population scale of 5.5 million. So at least that is possible. And the data quantities are not massive. They're not unmovable. So sometimes I think we sort of say we can't move data around because it's too big. I think actually it's more to do with, it's not actually necessarily too big, but sometimes it's not a secure thing to be doing, and it's not a necessary thing to be doing if there are other methods of querying data in situ and bringing analyses together in different ways. So maybe that's not quite an answer to your question, but it's a few musings on the general topic. Others, I'm sure, would like to contribute.
Thanks, Cathie.
Cathie.
So I was just going to pivot off that a little bit and just think about where next for trusted research environment. So you've talked a little bit there about, Cathie, about how we get more complex data sets in and linked. And we've heard already several times this morning about AI as being the future in this space. I just wondered, kind of from the panel's view, like where are we going next with trusted research environments that will continue to maintain their sort of their relevance and their ability to change the kind of the practices that we're looking at. Maybe I'll come to you, Davide, first.
So if I got properly, your question is about, which are the next steps we see as needed for a trusted research environment. So so my opinion, there is a lot of need for portability in the sense of, let's say, building, let's say, trusted research environments that can be deployed quite seamlessly, independently on the physical support. So they could be deployed on the cloud or on premises, or even in hybrid environment, which is, I see, the future in case we would like to perform in the TREs complex analysis, like genomics, for instance, right? It might consist in different steps, and each steps might require a different local environment. So I think portability is one pillar that should be, in my opinion, achieved in the future. Second pillar would be, in my opinion, as well, flexibility in the sense of achieving more a better way of customizing these TREs for different kind of users.
Thanks, David. Anybody else want to offer a view on that?
Can I add one question for David and Cathie and Petra?
Can I just add my opinion on what just has been asked? So the next steps for TREs, I was mentioning previously a good example where UK is leading, and we are looking at UK. There's another example where I think Europe already took good steps, so European Union. The Euro privacy certification. Yeah, we were just talking about the standards, norms, criteria for trusted research environments. And I think it was at the end of 2023 when the Euro privacy certification endorsed by the European Data Protection Board has come up. And since then, several certifiers have been accredited by the European Data Protection Board that can, on the one hand, provide support for the preparation for Euro privacy certification. On the other hand, then others can do the certification. And this Euro privacy certification has exactly this list and the norms and standards. Some are international standards like information security standards that are part of the Euro privacy certification, ISO 27001, for example. But there are additional criteria on top of this to ensure the privacy. So there is something in place that can be used, and I think this is very useful and also was required as by European law. The GDPR foresees such type of certification. What is needed very much, I think, is a network of trusted research environments throughout Europe, UK, Switzerland, European Union, where data can be exchanged. We have talked about interoperability. A very important aspect here is that it would need a trusted digital identity provider for the citizens of the different states, the member states of the EU, but the UK and Switzerland, for example, as well, Norway, to be able to then really access these networks of trusted research environments. So there need to be agreed upon standards on trust levels, for example, for identity providers in order to realize such a network of trusted research environments. And this network infrastructure is completely missing in the European Union. A nice blueprint coming from the UK is the UK Biobank. We also use data from the UK Biobank. Many researchers do. I know many. And there was a change actually over the course of when we used the data, namely they introduced these trusted research environments. And now the researchers are required to process the data in this trusted research environment provided by the UK Biobank. And this should be a common practice. I know that the health data access bodies in the European member states that should realize the European health data space that you might have heard about, they are struggling with providing such trusted research environments. And this is a big gap presently. And I think there we need to move forwards. And again, we can look at the UK and some solutions that you have already in place.
Thanks, Petra.
There is a general question to all of you panelists. from the future prevention of the diseases and also secondary use of the data for the TREs, what steps are needed to ensure that interoperability across countries include that includes diverse population data, so disease prevention and research is equitable as well as innovative.
Was that question for David?
This
Yeah.
is for all the, yeah, please go ahead.
Yeah, can bring my opinion in here. So I see a trusted research environment as a backbone for this to happen. There is another layer that is equally important if you want to federate data. So I think data federation across countries or across even data providers or stakeholders has two arms. So one is the, let's say, computational interoperability, if we want to call it like that, which is what we are now talking about. So trusted research environments, for instance, could foster data federation from the computational point of view. But the other arm, which is equally important, is the semantic layer. So how we translate data that are provided with different languages, so to say, from different stakeholders into a common language. And these are two arms that need to, be taken into account in parallel if we want to achieve what you are actually hoping to.
It's David, thank you.
Thanks. So I have a final question. I might start with Ashley. So we've talked, and Petra mentioned trust then. Ultimately, this is data about our citizens, about our patients, and how we kind of convince everybody or kind of continue to maintain that trust that the things that we are doing are responsible and are impactful. And I suppose my question, Ashley, is are we doing enough right now?
Good question. So I would say the direction of travel over the last 5-10 years, we're certainly doing a lot more now than maybe we did 10 years ago. I think that certainly we could always do more. Not to use buzzwords, but I guess for me the key thing here is the word that's already been mentioned this morning. It's about co-production. So it's not a novelty just to include it because you have to. It has to be embedded from the start, really early at the design stage, throughout the process, and then in terms of interpretation and impact at the end. I'll use an analogy that I host a team of data scientists. They're really good at using data. They don't understand what it means at the coalface from a service delivery point of view, from a lived experience point of view. So they can certainly support part of the process, but they can't know everything. And I guess this is where we really need to understand now, and coming back to the topics earlier around federation and interoperability, as we expand the types of work that we want to do, we have to recognize we need to do it in a multidisciplinary field, and bringing all of those expertise and voices into it has to be core to what we do.
Thanks. Anybody else have any views on kind of that public trust piece and how we kind of maintain and improve that?
Yeah, so if I may, our experience is if we talk to patients and also relatives of patients, they usually say, please use our data. We want to see the innovations that help our diseases. Yeah. And there were also surveys conducted actually systematically, and this was the same picture, yeah, that the patients actually, they quite trust and they want to see progress, and they are not so doubtful as it is always thought. The doubts comes more from the legal people, yeah, and I think it's really important to show the society that there are trustworthy technical and organizational solutions in place, yeah, where, for example, also the patients can exert control over their data, access their data, and all this would really increase the trust. But the trust of the patients is not really the problem or the barrier, I would say.
Thanks, Petra. Is there any further questions that we have from the room? Oh, Emma. you want this one?
Thanks very much. And, you know, we work across the UK and obviously with a heck of a lot of different data owners. It's an observation of mine that data owners obviously want to be seen to be only giving access to data to the right people for the right projects. But it's an observation that their systems for making those decisions haven't really evolved in some cases from the days where you'd send out data on an encrypted CD, where, you know, you were entirely giving over that trust, to these days where it's portal access through a trusted research environment. How do we kind of give data owners confidence that modern systems and processes are in place, that data access procedures don't have to be as complex?
I'll look to Ashley to start.
Yeah, so it's a really important point. I guess I'll just come back to that word once again, trust and transparency. So when you're working with a new data owner who wants to share their data with you, I think where we found the greatest success is showing examples of where we've done it before, and in lots of cases putting them in contact with other data owners who also had the same questions they did, because the questions they have, they're not trying to be obstructive, they're just trying to manage their risk portfolio. And let's be honest, it's the Daily Mail article, other newspapers available, where you don't want your headline on the front where you've done something and you didn't do enough due diligence or you didn't put things in. So it just comes back to, it's a journey, and you have to go on it with the data owner and then ensure you've got trust and transparency around how you'll use the data, how it's stored, how it's accessed, and then it's that feedback loop. And in some cases, like we do with Sale, it's allowing the data owner to be involved even more so in the process if they want to be. Some don't, some do. So it's providing the level of involvement they choose to have in terms of sharing their data.
Thanks, Ashley. I think Cathie, raise your hand, so you're looking to come in.
Briefly, yeah. So Emma, thank you. Great question. Nice to see you. I didn't know you were there, but I recognised your voice. I can only see the back of your head. So it's a really important question, and I think part of this is about changing the narrative. So thinking about the kind of the flip side. What happens if we don't use these data that are being collected and exist and that have the potential to address so many questions that are of relevance for public, patients and society? So, and to provide a kind of incentives framework that enables the custodians and the providers of data into trusted research environments, which is now, as you rightly say, where they're handled, where it is we do have a more safe and secure paradigm compared with before, but to provide them with incentives so that they get brownie points for making their data available. It's a rewarding thing for them to do, and I'm sure there are ways in which those incentives could be built in, but also by not kind of by government and other major central organisations absorbing some of the liability. I think this has been one of the issues in the UK with the provisioning of data from general practice, has been that individual practitioners in their small practices feel a sense of responsibility and liability for anything that goes wrong, which means that it's really hard for them to flip the narrative the other way and see the risks of not having the data used for public benefit. So if we can change the narrative and change the kind of liability, the ownership of the liability, and change the incentive frameworks, I think we would be in a better place. And otherwise, I agree with everything Ashley said.
Thanks, Cathie. And I think that point about the fear of data controllers is so important here. And as Petra said, it's not necessarily that the public themselves dislike the idea of these things, but it's kind of when you get into that sort of the bureaucracy and the liability issue of those data controllers. Anybody else would like to come in on that final point? Nope. Well, I think we'll wrap up there then. So I want to give my thanks and on behalf of everybody to Cathie, Davide, Petra, and to Ashley for a really good conversation. And I will hand back over to the next stage.
Thank you.
Thank Thank you so much, everybody. I would ask for a special applause for Alex Newberry's fabulous moderation with 10 minutes delay. Always calm, keep calm, keep calm. And we managed at noon. So we are now going to do a cybersecurity panel discussion that will be shared by the Chief Information Security Officer of DHS Wales, and I'm pleased to introduce, I get my little Mark Edwards, and Mark is Chief Information Security Officer of and Head of Profession for Cybersecurity at Digital Health and Care Wales, responsible for implementing and running the Enterprise Information Security Programme across NHS Wales. This involves identifying, evaluating, mitigating and reporting on legal, regulatory, commercial, digital, data and technology risks in a cybersecurity context while enabling and advancing business objectives. This is very important. It's really a pleasure to have you here, Mark, and for have you taking time off your busy schedule to be here with us. And thank you for sharing this panel discussion, and over to you.
No, all good. All good. So yes, fortifying health data. And sorry, as we were warming up, I was sharing reflections from my last NHS CIO role, where I was both the chief or senior responsible owner for data and the director responsible for major incident planning. So I had to plan to make sure things didn't go wrong and then plan for what happens when they did. Yes, obviously good to get all the panel reflections. Just the quick introductions. Mark has been kindly introduced already by Paul. David, thank you again for joining us, following from yesterday. So Acting Head of Welsh Affairs at the Information Commissioner's Office. And if I can also introduce Abel Ahmed to the room. So Abel is Principal Consultant CISO for Atos. First question, if I can actually come to David, if that's right. So I suppose a quick perspective on the sort of current regulatory view of cyber.
Okay. Apologies to all those who had to put up with me yesterday, and now we're having to do the same again today. I feel like I'm hogging these sessions a little bit, but it does show the wide range of work that we do. So cybersecurity is quite frequently a component of information security, which goes around, which has to secure the personal data that we hold. When it goes wrong, that's usually when people come to us, but we do loads of things like this to try and get the awareness up and make sure everybody's aware of it in beforehand. And certainly for cyber, it's been really interesting over the last few years, I think, to watch it become part of the national conversation. It's moved from a niche aspect that only certain people and nerds like me know a little bit about, and it's moved more. I think it was yesterday, there was another cyber breach yesterday involving a nursery. You may have seen that story. That's a very live one. Jaguar Land Rover, Marks and Spencer's this year as well. These are all things that are huge, and I think ransomware is one of the key issues as to why they've become, because they can do so much damage to such a wide range of businesses as well as customer bases, and that's certainly an aspect of what we've seen as well.
Well, thanks, David. And Mark, if I can sort of bridge that over to you. So against that continually increasing threat backdrop, what's the role of the CISO and how's that evolved?
Okay, so that's a really good question. So very much when I first started my role or started working as a CISO, senior security influencer, it was very much policy-based. Thou shalt not was our sort of motto. We controlled everything, just cybersecurity controls. Over the last couple of years, it's changed dramatically, the role, and now we've seen more as a business enabler. And you know, I come from a private background where I've done quite a bit of sales in my life, and I think my sales and sort of influencing skills are probably more important than my technical skills at the moment, because we've got to get buy-in from the business, and we've got to make sure that they can do what they want to do and do it safely, rather than stopping them from doing things that we don't want to do, while still remembering that we've got to protect critical data. And I think artificial intelligence is a great example of that, because I've never seen such a technology. I've been in the industry for 30 years, and it's just been an explosion of AI. Everyone's using it. All the youngsters are using it. All the staff members are using it, absolutely every level. And we can't stop it, and we don't want to stop it. That's all we've got to do, is make sure that we put in sufficient controls and education so that people can use technologies like AI safely.
Yeah, no, absolutely, Mark. And sorry, Dave, jumping back to you as well. So, I mean, it's an evolving picture, and I remember as a trust CIRO, actually appreciated the ICO not just as a regulator who was looking over my shoulder, but actually as a guiding organisation. What would you now say against that backdrop is the sort of recommended best practice that the ICO is putting forward to the provider organisations?
In many ways, it's a lot of the same messages from yesteryear. Train staff. There's that link between the human behaviours that then allow the bad guys, the bad actors, into the data scene. Phishing is a great example. If you've got a member of staff who's going to drive a forklift truck, you don't just let them at it, but we do it with email and we do it with computers. You've got to train people and you've got to enable them to be able to spot the issues that are there. There's a raft of guidance that's out there. There's lots of good guidance on the NCSC website. We've got lots of guidance for smaller organisations usually, but the same rules apply to there. You've got to know what data you have. The list is endless really, but get the basics right and a lot of the rest will follow. And I think, as Mark says there, buy-in, that senior level buy-in, and it pervades down through the organisation. That's where we see the most effective organisations in place, I think.
Mark, obviously great for us to get the support and the guidance from the ICO, but actually we're all facing these same challenges, aren't we? All the different organisations. What would you see as the way we can support each other through collaboration?
Okay, yeah, I think that's key, and that's one of the advantages we've got in Wales is that we're a small country, 3.1 million people, but we're big enough to actually make a big difference there. But it's small enough to collaborate, and I think that what we've shown is throughout the NHS in Wales, sometimes we don't collaborate as much as we can in technology, but that's probably an understatement. But when we do, we collaborate really well. And one thing we've done over the last year, which was put in place by my predecessor, was deploy a nationwide security information and event monitoring solution. So now we have a single pane of glass into all the threats that affected the NHS in Wales and all the remediations we can do about them. So we can see through all organisations. Each organisation has their own dashboard where they can see key performance indicators and threats to their organisation, and then we can react as one to any of those threats as they emerge. And I think, to the earlier point was, it's in people's minds at the moment, the current threats. The one of great concern to me was the one yesterday against the kiddo nursery breach, and that just goes to show how low the cyber attackers can stoop. Because in the past, we think maybe healthcare isn't going to be affected because we're not for profit, we save people's lives. But this shows the 8,000 records of young children in nursery, and pictures of being stolen, exfiltrated, and they demanded a ransom to actually publish otherwise they'd publish those records to criminals, basically. And I've never known a security attack as bad as that. So that's the reason we're all doing this. That's the reason we've got to collaborate together, and it shows that no one is immune from a cybersecurity breach.
No, I think that's a good point, Mark. And obviously, we often consider the cyber threat in terms of, and as with that, the threat to privacy, the threat to the record. Atos, in our broader work with other industries, we support an awful lot of critical national infrastructure of various nations. And of course, we've got to remember the NHS is that. If you wanted to cripple this nation, start taking out hospitals, they can't function. So it's a big step change in threat.
Yeah, absolutely, and I was at a conference last week, and it was very insightful. They said that even attacks on other critical national infrastructure or any major disaster in the UK, the NHS and the health service will actually be impacted from it. So we are a part of critical national infrastructure, whether we like it or not.
Thanks, Mark. Abel, if I can come to you, obviously, I suppose moving down a level in terms of the detail, the last day and a half, or a couple of days, have been very focused in on our ability to share data. I was wondering if you could share your reflections on how architectural principles like zero trust can actually be an enabler to sharing rather than a blocker.
Yeah, absolutely. And it's not just new technologies like zero trust. We've also made tremendous advances in how we deal with cyber and the lessons we've learned, including how to simplify it. So it's not a bad news story, right? The attacks get worse, but we have new and better ways to deal with it. In terms of zero trust, that sounds really scary. It sounds like we're all going to have to authenticate every time we want to access something, and that can be really business disabling. But the way something like Zero Trust can certainly help us share information much more easily, and by the way, it gets rid of, if we use it properly, the idea that we have to have copies of information in a shared patient record, for example. If you try and access information in a system, you'll be challenged for your role, and then you'll be given access. That's role-based access control. I think we all know about that. Zero Trust brings in something else. It says, yes, we will check everybody's access to information more continuously, but because of new technologies, you don't have to keep signing in with your password. It will use different methodologies, such as attribute-based access control, which has been difficult in the past, but because we've got much better technology, faster chips, the information that it will evaluate you on is already there in the system, and it's being constantly collected. So when you log in, it will already have that information, and therefore when a consultant surgeon wants to access somebody's GP record, Zero Trust will be able to evaluate whether that surgeon can be allowed to access that record using other information about them.
Yeah. Thanks, Will. Aware of time, and I'm sure we want to close fishing, but so perhaps one last reflection from each of the panelists, and I referenced at the start my previous role that required me to be poacher and gamekeeper, in that I needed to make sure that people couldn't break in. That's an impossible task, they'll get in eventually. And perhaps therefore more critically my role as the director responsible for major incident for a trust. What do we do when it goes wrong? Certainly at that trust I did a lot of work with my executive on practicing for when it goes wrong and how we would respond. Typically the scenario involved me being off on holiday somewhere, so I could actually run the event. But so perhaps if I can go through each of the panel in turn, so perhaps start with Abel. So your reflections on how we make sure we are able to respond when something happens.
Well, the thing about responding to a cyber attack, luckily, even though we've seen so many incidents recently, for each individual organization, it will happen at some point, but it doesn't happen that often, otherwise we'd all be dead, right? So the thing is to practice and prepare. And so it's important to get into scenario-based practice with a third party, preferably because they can take a step back. They will run scenarios for you. It's a good idea to get all your execs, keep people into a room. They will come up with scenarios. They won't tell you what they are. They will kick off these scenarios and then say, right, what are you going to do? And then they'll also build in other injections, such as, oh, we just had a news broadcast from the BBC. They're mentioning your company. You've just had a massive breach. Everybody's really upset. What are you going to do about that? It's just getting everybody operating in a controlled way to deal with that incident. And after you've completed it, you'll learn whether your processes are good, what needs to be improved, what doesn't.
Mark, same question?
Absolutely correct. So I've seen there's a big shift from just protection, detection, to resilience. So, you know, how do we respond in the event of a disaster? Because, as you mentioned, it is a case of when, not if, and I'm sorry to be pessimistic about it, but we've got a plan for that. And if it doesn't happen, great. But we've recently run an incident response exercise, an all-wheels incident response exercise, covering exactly the same points you mentioned. And there's some great learnings for it. So we had all 13 organisations in NHS Wales collaborating to do a third-party incident response. And some of the things that came out of there were absolutely, mind-blowing, really. And some ways we were completely covered, and other ways we discovered weaknesses straight away, such as out-of-band communication. So if we lose our Microsoft platform, how do we even communicate to do the incident response? So it's little things like that that we need to pick up on. And no one wants to get breached, but we have to make sure that we know what to do in the event of a breach. And I always think about, as well, we need to look at ransomware preparedness and how we counter specific threats like that. And if we were hit by ransomware, how would we deal with that? because a lot of the protection we have in place will deal with traditional disasters such as fire, losing a data center. But if everything is encrypted, and quite often your backups will be encrypted, sometimes you'll have a secondary breach as well. How do you deal in that scenario? It's a completely different scenario. And we were supposed to have Health Executive Ireland here today to speak to us, and we've learned a lot from them, and their experience of a real incident. And it's in areas like that they had their staff members going off in ambulances, so we have to consider that the welfare and resilience of the staff members as well as the resilience of our data.
Yep. David.
Well, we're the bad guys in the breach reporting chain, aren't we? Because we're the ones that can take action. I think it's worth. I mean, there's a legal duty first of all to consider whether or not there's a threshold, whether or not an attack meets the threshold. My advice is always to try and assess the personal impact, the human element, as quickly as you can. If you know what data you hold, you should be quite straightforward. As Mark says, I think it's inevitable. You probably, in the course of this conversation, our organisations have probably repelled hundreds of cyber attacks as we speak, and it's inevitable that a breach will happen at some point along the way. So being prepared for it, knowing where your disaster recovery is, as you alluded to there, David, then these things will really help that go smoothly. The sort of things we're looking for, keeping that rationale behind your decisions. Just to bring it to life, you may remember the advanced data breach, which we issued a monetary penalty for earlier this year for £3 million, and that was an NHS supplier. That supply chain is key. So again, monitoring that. How are you going to think of every eventuality that could cause a breach and have a real impact on people's lives?
Advanced being a supplier to one of my old trusts. So yes, absolutely. Wonderful. Well, I think we're probably closing down to move on to the next session. So may I ask everyone to join me in thanking our panel for the chat? And thank you. We'll pass back to Paul.
David, there is one minor comment from online.
Thank you so much, dear guest speakers, and a round of applause for David for this impeccable moderation. Please, David is being a key asset for this summit in contributing. Thank you so much, Padma. So let's now introduce our closing session. This is going to be a very interesting session as we are finishing here also our joint charter with lots of inputs from the guest speakers in the lightning talks and others that would moderate the World Cafe tables. And for the ones who have notes from this morning, we will send the link to the shared document where we are generating the input for our joint charter. So I'm not going to ask the closing panel to comment on that for the moment. I think it's really too much at this stage. We are going to mature all these ideas that were wonderfully generated by these discussions and at the tables. But instead, I think we can do something else. And I'm sure Rebecca Cook, already here present, will have a way to figure out a nice closing panel. This panel will be hybrid in the sense that there are our guest speakers are attending remotely. We have representations from all over the world. They are already online in different time zones. This is incredible and very, very thankful for you guest speakers online that are joining, and also to Padma, Roy for making an excellent hybrid co-hosting. As I'm hosting here in the room, Padma has been hosting online discussions, and altogether we'll compile an interesting document, I suppose, and also relevant and actionable on what we call the joint charter for secondary health data usage. Without further ado, I'm going to introduce our closing session chair and moderator. Rebecca Cook is a Chief Data Officer at Digital Health and Care Wales. Is an accomplished leader with 19 years of experience in digital and data roles within the NHS Wales. Joining DHCW in 2005, she has driven transformative change through data, focusing on health and social care innovation. As Head of Information Design and Standards Development, she champions data-driven decision-making and strategic partnerships to enhance healthcare delivery. A round of applause for Rebecca, and thank you for joining here on the close.
very kind of the comms colleagues who wrote that about me. Thank you very much. So some of you may have met me yesterday. I was participating in the Five Nation, I think, panel discussion. I'm going to stay here. I can stand, okay? Can stand or so it was quite a surprise to me to be moderating this panel. So I haven't met the panel in advance. Apologies, I'm stepping in. But I'll try and close this up with some reflections on the event over the last few days and some next steps forward, which I was prepared to do. So online we have, I should open my list before we try and start this, or I'll do a terrible job. Now I'm opening day one. That was yesterday. Brilliant. Okay, so I should have Jerome online. Do I? Yes, I do. Nice to meet you. And Inaki, is that online or in the room? Inaki, would you like to join? Thank you. I should also have Jason online. Yes? Okay. I mean, the first step is to get your panel in order, isn't it? So we'll do that first. Okay, and Osama's online as well? Yes, Osama. Brilliant. Perfect, and they're both here. I'm just going to trust that they're here and they're going to speak when I ask them to speak. So firstly, should we just do some quick introductions? So I'll start in the room. You know me, and I'm going to pass over. Do you need a microphone?
Yep. I think I've introduced myself previously. So it is Iñaki Gutiérrez Ibarlucea. I'm the Director of Health, Innovation, Research and Evaluation of the Ministry for Health in the Basque Country, trying to be independent, but still part of Spain.
Thank you very much. And then if I can ask Jerome would you like to introduce yourself quickly online, please?
So, Jerome De Barro, so I'm a policy officer in the European Commission, so in the Directorate for Health. And over the past few years, worked mainly on the European health data space, so the regulations for the use and reuse of health data.
Perfect. And Jason, would you like to introduce yourself?
Yes. Let me just make sure that my video and audio are working properly.
Audio is working, but we can't see you yet.
Okay. Let's see. Oops.
Yes.
Now.
You've appeared like magic there on the screen.
Okay, good. So thank you very much for the invitation to participate on this important panel with esteemed colleagues. I am Jason Lee. I'm the director of the Healthcare Forum at the Open Group. The Open Group is an international standards development organization that works across multiple industries. In the Healthcare Forum, we have been working on interoperability going back 11, 12 years ago. We became the steward of the Federal Health Information Model, which is what the US government had developed through its architectural resources, but ultimately asked us to become stewards of and sort of went the way of the private sector. More importantly, I think for this conversation, our focus has been on a value-based architecture. And so this is an introduction, so I'll talk about that a little bit later. Thank you.
Perfect, thank you. And Osama?
Hello, everyone.
see you.
Thank you very much for having me here. So my name is Osama Al-Hassan. I'm a software engineer by training. However, I carry more than 23 years of experience in digital health. I'm actually a digital health specialist at Dubai Health Authority, which is the regulator of the healthcare system in Dubai, UAE, where we have a lot of activities around health information exchange and genomic. We have also a national genomic project, and we do a lot with regard to policies and regulations relating them together. Thank you.
Perfect. And if I'd have met you all in advance, I could have really practiced on the pronunciation of the names. So finally, Padmapathi, is that correct? Did I do a good job? Perfect. Thank you. No.
Sorry.
Yes.
Yeah, I am Padma from Data First AI Later initiative. So I have around 25 plus years of experience, and here Jason Lee is already there. I was a previous chair of the healthcare forum. So yeah, that's about me.
Perfect, thank you. And thank you for bearing with me on those introductions of our panel. So I think the first part of the conversation we wanted to explore within this session is around policy and regulation. So Jerome, would you like to share with us some of the EU priorities for the European health data space?
Certainly. So the European data space is a recently launched regulation, so it was adopted and came into force March this year on the use and risk of health data. So what it does is to provide a framework for enabling, firstly, cross-border exchange of health data. So making sure that all European citizens have access to their own data and are able to use it outside their country. Or, for example, one of the services enabled is e-prescription. So the idea is to make it possible for Europeans to have prescriptions issued in one country and the medicine retrieving anywhere in Europe, really. That's what we do when it comes to what we call primary use, so healthcare. And then we have a framework for the reuse of health data, so for secondary uses, where here we define a set of rules for making it possible for a researcher to access health data from any country in Europe for agreed purposes. So, and for this, we also have an infrastructure to enable communication. And as part of the rule, we also set a series of measures, let's just say, to ensure that when data is made available, it is done in a safe way. So that implies a new governance at member state level and technical requirements. For example, data is only made available in a secure processing environments. That's just a fancy word for TREs, really. So really trying to harmonize how data is accessed in Europe for use of health data. So moving on from this fragmented approach we have in Europe, where every country have different set of rules for different types of data, sometimes not from provider to provider, really. So we try to offer an alternative with this harmonized framework.
So I've been following actually quite a lot of the EHDS news. Particularly, we've been looking at the EHDS standards around data exchange as part of the work that we're doing in Wales to exchange data across the country using our sort of All Wales platforms. What are the sort of timelines for I suppose achieving the ambitions of the EHDS?
So in terms of timelines, as I said, the regulation was adopted. So the text was agreed in March this year, and we will now have 4 years for its implementation. So the objective is to have by 2029 this broad access to health data by every EU citizens, this possibility to have that data accessed by any healthcare professional in Europe, and the framework for the reuse of health data, so making it possible for our researchers or innovators to access the data at the same time. So March 2029 is when everything will be in place.
Thank you. And I threw that question at you. It wasn't written down, so thank you for answering that for me. And you were going to provide us, I think, a bit more of a regional perspective as a sort of participant of the EHDS.
Yeah, well, we are one of the sufferers of the regulation. No, I'm joking. Now, I think there has been a incredible transformation on how Europe was approaching to data and data sharing. I think yesterday the example of Wales was tremendously relevant for many senses, and also it was a way to understand how we can do it also at the European level. I think it was the difference of shared data and data sharing. That is another thing. So at the very beginning, perhaps the Commission was a little bit naive regarding the European data lake, and I think there has been a nice conversion right now to something that is much more attainable. So it is federated data with a purpose, and calling to I would say regional data lakes that are of sufficient quality and sufficient sophistication that could be pulled together in a federated way, answer questions that have Europe as a whole. On the other side, it is true that one of the challenges right now, I don't think it is on the, or they are on the side of technology. Probably technology has been faster in many senses in providing tools in terms of interoperability, in terms of capacity to process data. I think the challenges right now, it is, on the one side, it is the incorporation of professionals and patients in this equation, that the data locally are of sufficient quality and sufficient sophistication in terms of being put together, answer the questions that we have as systems. And I think it is the commissioner, well, the person from the commission. I think they are in the correct direction right now. So it is offering the services for citizens. Another question, it is what we haven't solved as a whole in Europe. That is offering similar systems and similar healthcare to any citizen in Europe. That is, I think, the challenge right now. So it is independently that we can receive prescriptions that are obviously subsidized or reimbursed locally, or independently that we can be treated when we are on holidays in Sweden, or we are on holidays in Norway, or we need to work in I don't know, in Italy. The other challenge it is if we can ground on the basis of data a system that can provide a similar healthcare for any citizen in Europe, and I think that should be our goal. If we can do it on the basis of data, for sure, but I think nowadays the breakthroughs and also the challenges and the boundaries and the barriers are much more on the political side than on the technological or even citizens' will, and perhaps those are things that we are not going to solve in this forum.
Yeah, I think we're seeing some of that too. I think we invested quite a lot in terms of our technology stacks and our infrastructure, and I don't think the challenge is necessarily technical anymore. It's more about the politics and the bureaucracy and some of the governance, and how do you break through that. And presumably across Europe, I think you mentioned it there, we've got different levels of maturity in terms of data readiness. So we have the same challenge, so it's great to say we're going to adopt international standards like HL7, but if your source system's data quality don't comply with those standards and can't be mapped to it, or it's incomplete or invalid, then actually the plan sort of fails at the first hurdle, doesn't it? So I think that's really insightful, and it'll take us on quite nicely, I think, to Jason's input from the Open Group, particularly around that standards and interoperability agenda, which really is the bedrock of getting that data sharing in a meaningful way. Can you share with us perhaps some US perspectives on how standards can accelerate some of that trust of data and data sharing?
That's a tall order. I can say a little bit about that. And that's going back a little bit. I've been working in healthcare for over 30 years, and our focus on interoperability in the healthcare forum took us down a number of paths. Certainly, we came to the conclusion that interoperability is a people problem, it's not a technology problem. We looked at FHIR very carefully and concluded that FHIR works very well for one-to-one or one-to-X agreements to exchange data, but in the end, you ended up with a bunch of individual agreements which themselves don't match. And what is needed, therefore, is a common logical information model. We spoke at The Hague to the World Economic Forum about this. Data interoperability is a problem wherever you are. This conference has been excellent on describing efforts to address that issue. What we have been doing in the healthcare forum, and I do want to call out Dr. Roy's excellent leadership in the forum and her continued participation in the area of cybersecurity, healthcare security. What we've been doing is really working on the development of a larger framework within which this organization and others can think about data for sure, and its centralized importance in providing healthcare. But there is an even larger framework, and that is, how does an organization provide value to its patients? And value is simply defined as quality over cost. So the interesting and helpful thing about that concept is that you can, if you keep costs the same, you can increase quality a little bit and you've increased value. Or you can actually keep quality of care the same, however it's measured, and decrease costs, and value has been increased. So in this framework, we're developing a standard which essentially is more of a ground up approach. It's a tool that works across any healthcare environment, any industry actually, but it's specific to healthcare. And it's focused on specifying the value stream that one is interested in. So for example, we've looked at security, we've looked at what happens if there's a major digital disruption in a cancer care center and you're providing chemotherapy care to patients. How do you ensure that those chemotherapy patients continue to get care despite a disruption that you would think would stop the system? Obviously, those patients need to continue to get care. So in this framework, the user, the person on the ground, specifies the value stream end to end, specifies the stages of that value stream. So the typical generic approach there is what, in working with our Dutch colleagues, is called the diagnostic therapeutic cycle. So you come in, a patient wants to know what's wrong with them. They come into the hospital, they get diagnosed. That may involve a number of labs and images. A diagnosis is made, a treatment decision is offered. The patient decides to either go forward with that treatment or not. The treatment happens if they do decide so, and then they're released from the hospital. And that could be to home or that could be to a coordinating care facility. So that's, as I say, the generic framework. the way this works briefly is for each of those value stream stages, and I specified the diagnostic therapeutic cycle as the generic one. One then goes about specifying what are the capabilities that are required. Clearly, data is central to this, but knowing who are the people and what are the roles and what are the skills and processes involved, as well as the information and the data and the technology and the applications. If you have that whole set of factors, which are specified in TOGAF, which is the grand standard of the open group, I would say, then you're able to map out the very complicated landscape. And in understanding how data fits in the larger picture of capabilities, then it's possible for decision makers, for high-level executives, and the managers that work for them, to see the big picture and to see where the gaps are and to understand what kinds of actions need to be taken under certain circumstances. So that's a summary of what the value-based architecture does. It's a much larger framework. We're looking forward to working with Paul and Padma and Data First, AI Later, and developing this framework so that it will be useful to the members of this fine organization. So thank you.
Thanks, Jason. I'd certainly be interested. So a lot of that resonated with us, and I think understanding the value is really key, isn't it? I think lots of people jump straight into solutions to different problems without really understanding the value that they're trying to unlock by solving that problem. So, Padma, did you want to come in? You had a nice reference there from the Data First, AI Later. Did you want to add to any of that?
Yeah, so my perspective from the lens of data first and AI later, basically the foundation for the digital health is always the data first, right? And policy regulations are not just about bringing compliance, but they are about creating trust, as the previous speakers also mentioned. If we don't get the governance in place first, right, then no matter how advanced our AI, it won't be adopted at scale. And also, Jason rightly mentioned on the standards and interoperability that our work we have been doing from the open group. I often say that it's where our philosophy truly comes alive. Is interoperability is the engine that allows trusted data to flow, and the global standards, as you also mentioned, the fire and also HIPAA and GDPR. Without global standards, AI always be working with fragmented insights. But when systems are aligning, suddenly we have the ability to use data securely across the borders. And also, even we have seen in the trusted research environment the speakers mentioned, I also had many questions clarified. But that is the reason we need to have these systems aligned. Suddenly we need to develop that ability to systems talking to each other, and data is flowing securely across the borders, accelerating research, improving patient care, and creating trust in the outcomes.
Thank you. And I feel like I need a t-shirt that says Data First, AI Later. So I'm a Chief Data Officer at Digital Health and Care Wales, and you'd be surprised how many people invite me to a conference to talk about AI, and I'm not the Chief AI Officer. But my first question is, what's your data foundations like? We just want to do the AI stuff. Well, you need good, solid data foundations. You need the data to be there of good quality. You need to have those governance and frameworks in place. So, really made a friend here, I think, stepping in to moderate this panel. So I think finally I'm going to come to Osama. who I think is on the screen. Hello. And I suppose once we've got a lot of those sort of governance right, and we've thought about the standards and the interoperability and the regulatory frameworks, how do we start to put in place those practical pathways for embedding AI? So we've done the data first. How do we sort of move forward with those practical AI use cases?
Thank you very much for the question. So I have some few comments on the slogan of data first, AI later. I think maybe it's now becoming more urgent now. I think it could be data today and AI tomorrow. So we cannot wait for so long, where there's a lot of pressure coming from industry, coming even from patients, asking for more utilization of AI algorithm, not only on the efficiency side, but also at the point of care. And I believe that from the beginning, our approach to AI should be kind of risk-based approach. So we need to stratify use cases based on their attached or associated risk. And based on that, we can act. So some of those AI solutions, which do not directly affect the care in terms either of a diagnosis or treatment, these should be completely taken to a different path, comparing with AI solutions that are going to be utilized at point of care and may affect or harm patients if they deviate from the course of their actions. So we need to make sure that we identify this approach, that being a kind of like, as I said, risk-based. One thing I believe also from the regulatory point of view, that even individual regulators like a country or a city should not take the full responsibility of deciding whether this AI model is accurate or not, even when we look at their design or how they've been developed. This should be shared even between different authorities. There should be some sort of a mechanism for regulators to have some sort of registries of those AI models. So even if they got approved at the initial level, their implementation should be monitored, and all logs of these interactions or decision made, any incidents, any harmful incidents should be logged and distributed across all regulators, so we can identify that algorithm X is not working well in Brazil or in Australia. So maybe we can learn about that, and we can have a kind of like information that can help us to make decisions locally. So having these kind of like federated registries of AI algorithms, that would be very helpful. Having also some sort of a common societies of practitioners within AI regulation who can share experiences, do knowledge transfer from time to time. That will be also helpful for countries outside Europe and US to accelerate their regulation process. Thank you.
Thank you. So I've got data first, AI later, data today, AI tomorrow. Any other offers, let me know before I go to print, but I like them all. And AI is very much here today, isn't it? We know that. People are using it, and there are ways in which we should be using AI today. So I think that risk tolerance is really important. So I'm going to open up to questions, I think, to the panel from either in the room, or if anybody can tell me whether there are any online. And then I'm quite conscious of the fact that I'm standing between the end of your day, or maybe even the end of your week if you're finishing after the session. So I'll try and close this up after a quick offer of questions. Of course. Would you like a mic?
Because you mentioned about your offer for other designations, but I have here a challenge for the forum and for also our panelists, that we could be start upgrading our movement, data first, AI later, to another, but this is responding to kind of Rebecca. But perhaps we could start to say data first, AI better. And that's a proposal.
I like it. Thanks for taking up my offer before I went to print. I saw a really good slogan, actually. One of my team is in London presenting the last 2 days, and it said something like, rubbish in, disaster out, on a big sort of slogan, which was Get the Big Data London event that they're in at the moment. Okay, thank you to the panel. If there's no other questions, I've got a few words, I think, to round us up and close the Health Data Forum. So, I was going to start with good afternoon, everyone, because I wasn't expecting to moderate that panel. So, good afternoon, everybody. It's been an absolute pleasure to have the Health Data Forum hosted in Wales, and I just want to thank everybody who's participated, the speakers, the panelists, the moderators, the attendees, both here in Cardiff who have travelled, and I think many of who have joined virtually. I keep getting told we're live on different streams, which is really exciting.
And you work good weather for us.
We did put on the good weather for you here in Cardiff. I'll try and do that again next time if you're ever here. So I think the engagement and the insights that we've had over the past 3 days has really shown us what an impactful event this is. I've never participated in the Health Data Forum before. And the goal for this summit really was to drive change through data insight. And we set out to really explore how we can use health data to innovate, to improve care, and most importantly, I think, to build trust. So looking back at all of the sessions that we've had, I think that we've met that goal. We've made some really great connections. We've had some really good insights, not just from our sort of neighbouring countries, but globally as well. There's been a huge amount of ground. I don't know if everybody's been here for the full session. I missed a little bit this morning, apologies. But there was a sort of day zero on Wednesday where there was quite a deep dive session on working together to draft a joint charter on trustworthy secondary use of healthcare data, which was, I think, a really powerful start and set the tone for the forum going forward, focusing on patient engagement, governance, and equity. Yesterday was filled with, again, lots of incredible discussions. We explored a UK-wide and international approach to ethical AI. We tackled a bit of a complex question: who owns the data? Which was quite provoking. The cloud owns the data. We heard from really prestigious leaders, actually, like Michael West, who spoke to us about compassionate leadership. And we were challenged to think critically about the difference between evidence-informed and data-driven decisions. We also saw quite late, if you stuck around for the whole day yesterday, we saw a bit about how collaboration between social care and health can unlock better outcomes for society. And that's a theme that really brought our focus back to the people that we serve and the jobs that we do. I missed this morning. I've got plenty of note takers in the room, so I look forward to catching up on what I missed. But today was really about diving into the practicalities of a data-driven health revolution, looking at how AI can transform healthcare, the critical role of trusted research environments, or TREs, enabling secure and ethical research. And we address the silent but essential foundation of trust, which is cybersecurity and governance. Thanks always to my colleagues like Mark, who make sure that I'm being safe in what I do with data. So I just want to wrap up a few takeaways. First of which is, I think trust is not given. and it must be built and maintained. And that was a theme that was really strong, I think, throughout the forum, from discussing consent models to patient engagement, governance, ethics, to converge and create the trust. So it's clear that all of our work on data innovation is only as strong as the public trust that underpins it. And we must continue to be transparent and ethical in everything that we do, ensuring that patients and citizens remain at the heart of our work. The second takeaway for me was that collaboration is key to sustainable change. I think the Four Nations panel showed us sort of some of the power of cross UK collaboration. That's where I was this morning, actually, looking at what specific data endeavours we can take forward as leaders across the Four Nations. While the sessions like we just had on sort of global health highlighted the importance of sharing these sorts of frameworks across borders, whether they're bridging the gap between social care and health or aligning on national standards, working together, I think, is how we'll achieve sustainable change. And finally, from vision to reality. So we've seen some really incredible examples of how to turn strategy into practice. We've sort of looked at different ways to move from discovery to equitable delivery, and some of, I think, our challenge now is to take the ideas and the insights from the forum over the last 3 days and think about how we embed them into our daily work, how we continue to engage with the people that we've networked with over the period. So thank you everybody again for being a part of the really vital conversation. And I'm really confident that working together we can build a healthier and more equitable future through data. Thank you.
As always, thank you everybody, thank you all. A round of applause for Rebecca Cook. We couldn't have a better ending with such a strong messages. Thank you so much, dear guest speakers, for shining this closing panel with your inputs or participations and your geographies, because we're representing a global hybrid summit, and this is the reason why we are global, precisely on your screens. Thank you so much, participants and summit members, for your discussions. Your presence here is what drives us, and looking forward to keep you in the loop with the joint charter that we are going to create. I have to also to thank the wonderful team effort of the team. Reese, I sent you something on a WhatsApp. I'm not sure if you're able to put that screen here on the, this is a challenge. But first, thank to the IV team. This is the most professional IV team I've ever worked, facing huge challenge in terms of connections, but it was brilliant the way we all get supported here with this team. I'm making sure that I will put you on the reference on your website, if you don't mind. It's going to be something. I think also if Reese is able to face this challenge of putting the picture here, the incredible collaborative work that happened between us and DHCW, it was amazing, and the way all come through in harmony, it was fantastic. I can only imagine how patient citizens in Wales are being served by such a wonderful organization. By the way, they collaborate, they open to innovation. It's fantastic. I also have to thank the presence and acknowledge the presence of several Ministers of Healthcare that are present here throughout the session. I have Dr. Cabral from Cape Verde, the representation of Minister of Healthcare, who could not be here in presence. A round of applause, I think, for these participants that travel so far away to be here. Emadueno Cabral, thank you. I also have to acknowledge the presence of another Ministry of Healthcare, one of the most innovative ones in Spain, from the Basque Country, Iñaki Guterres. Thank you so much for your participation, your leadership. I think I've put him in 3 sessions and he didn't complain, including the closing, which is the 4th. So thank you so much, Iñaki, and your contributions were highly valuable. to our sponsors. Last word, all this dialogue is not possible without the participation, the collaboration of our sponsors, our global partner, MTG Research and Development Lab, that's supporting us in these two. Oh, that's the picture I would like to take. Thank you, Reese. Well, what a challenge. This is the starting of this collaboration process, and it was an interesting post, and let it reveal the enthusiasm that we generated with this collaboration in Wales. And specifically as a main partner in Wales, Atos, and in the person of David William Lewis, the sole representative. There were here few members. A round of applause to David, please, because he also contributed brilliantly to the success of this summit. Thank you so much, David, for your... Okay, and last but not least, a round of applause for all of you, please, because you are the stars of the show, participants, the ones who create the energy, the momentum, and who applaud the speakers. Thank you. I think we're off now, and it was a pleasure, and let's keep in touch all together.